Thank you, Francois. Good afternoon, and thank you for inviting me, Professor Kwasi. I was asked to really highlight where we are with the use of Fortunoffenamide in TB and also hepatitis co-infected patients, that's the HIV infected with TB. I have some research funding from Gilead and also from Viatris as well. So for Fortunoffenamide, it's now found across many international HIV guidelines. WHO has indicated the use of TAF with 3TC or FTC and DTG in special populations, those that may have osteoporosis, those that may have renal dysfunction as well, as populations where you can use Fortunoffenamide. The European guidelines as well highlight the use of TAF, in fact, highlighting it higher compared to TDF with BScHb and also combined with DTG as well, and other combinations where you can use TAF. Similarly, the DHHS guidelines as well, TAF combined with BScHb is the NRTI of choice. Then also it can be combined with DTG as well. But many people under the DHS guidelines, many of the people in the US, they are on BScHb with TAF as the combination. Recently, that was December last year, the International Antiviral Society, the US panel, recommended preferential use of TAF with BScHb, and also surprisingly, I think what many people were not expecting is even recommending the use of TXF, either TDF or TAF, in individuals who are taking rifampin. And we know that when you look at the differences between TDF and TAF, it's largely centers on the plasma and also the intracellular concentration of tenofovir. With TDF, it has a high plasma concentration with a short half-life, and this is the reason why it may be associated with some of the kidney and also bone disease events. Then with TAF, it has a lower plasma concentration when it's converted to tenofovir. But in the lymphocytes, it has a high intracellular concentration as opposed to TDF. And again, if you look at the intracellular concentration of the tenofovir disoproxyl fumarate, the active component, you find that it has higher concentration when dosed with TAF, converted from TAF as opposed to TDF. And we well know that TDF and TAF, they have, in terms of viral outcomes for HIV, viral suppression is equivalent, combined with either ovitegravir, in this case with cobicistat as a booster, and also emtricitabine. But also recently in our trial, we also demonstrated equivalence in terms of viral suppression between TAF and also TDF. This is in our cohort in a clinical trial we're doing in Zambia. We know that HIV and TB, these are two, as Francisca really did highlight, they go together, especially in our region, with people living with HIV having 18 times more likely chance of developing the TB disease. And again, we know that rifampin is a very key component in the management of tuberculosis, the drug-sensitive tuberculosis. And we need to be aware of the potential drug-to-drug interactions for those that have both HIV and also tuberculosis. Now, for rifampin and TAF, the interactions really, they are on the fact that rifampin is a ligand for the pregnant X receptor, and activation of this results in induction of target genes. And it's the P glycoprotein which largely is activated and the substrate for TAF. And once there is that induction, then you have this is involved in the intestinal and also hepatic uptake of tenofovir-lafenamide. So really the interactions are on the induction of the PXR receptor with activation of the P glycoprotein gene as well. And because of that, there was this trial looked at if you added an additional dose of 25 milligrams of TAF, this is in a health population, the volunteers, would they be viral, would they be similar intracellular concentrations and also plasma concentrations? You may not see this clearly, but the green line, that is the TAF with an extra dose of 25 milligrams compared to the TAF BD, the blue one. And you can see that the intracellular levels were lower, the plasma levels were lower by 15%, but still what was key on this, that it was still above what you would expected with the green line on steady state. And this was an important aspect in considering how possibly viral outcomes may be better. Then when you look at, this was a study by Marta and Madelina and team looking at the rifampin effect on intracellular plasma pharmacokinetics of TAF. And this again was in a healthy population, healthy volunteers, where TAF was given initially for the first 28 days, then rifampin added, and also after intensive PK sampling, moved from 57 to 84 on TDF 300 milligrams once daily. What was key here, you can see that rifampicin did lead to lower plasma concentration of TAF as expected, with the green one being the TAF. Then when TAF FTC with rifampin is added, you can see that the levels were lower, the ones in red. Then again, when you look at the plasma concentration of tenofovir, there was also lower plasma concentration of tenofovir with, you can see the wider margin as well in the plasma concentration of tenofovir. Now, the intracellular concentrations, rifampicin led indeed to lower concentrations of TAF intracellularly. And when you look at this line, this is when you look at the fact that despite the reduction in the intracellular concentrations of TAF and also tenofovir, the tenofovir disoproxil were still higher. The diphosphate was still higher compared with those achieved by the approved standard dose of TDF. So you can clearly see that the TDF one, that is the blue one, the blue line you can see down there, then also the red one, that was the tenofovir concentration, again indicating the possibility that viral outcomes would still be okay if you administered rifampicin with also TAF. And because the concentration of the tenofovir diphosphate is one which you are targeting is the intracellular concentration, then dose adjustments may not be needed when you give TAF with tenofovir. I know, Francois, you've been doing some study on this. But following this as well, we have an upcoming study where we are going to now look at both the viral outcomes, virological outcomes for the HIV and TB co-infected population, and look at the intracellular concentrations as well. But we are not just going to look at the rifampin, we are also going to look at the rifapentin as well, because it's one of the molecules which we are highly using for TPT. Then for hepatitis, going to hepatitis, again, it's a similar scenario. You have high hepatitis prevalence in our region with a lot of hepatitis B-related liver disease and also cirrhosis and hepatocellular cancer as well. Right now, the European guidelines do recommend the treatment for those who have hepatitis E antigen positive or negative with chronic hepatitis B. Then also when you have the liver enzymes, the ALT higher by more than 2 times the upper limit of normal, and also hepatitis DNA more than 1,000, more than 20,000. And the way you look at the treatment is to look at the hepatitis B surface antigen positive, and if there is chronic hepatitis, you start the antiviral treatment, and also those that are at risk of developing hepatocellular carcinoma and also risk of reactivation, there is an indication for starting treatment for hepatitis B infection. The treatment is largely in 2 aspects. Either you can give the interferons or you can give the antivirals, the nucleotide analogs. And with the interferons, it's only a small population, the younger population, and those people that you think are able to have immune system control. Then the nucleotide analogs, these ones you need not to worry much because they are well tolerated. And we have lamivudine as one of them, then key tenofovir disoproxil fumarate, and also entecavir, and TAF may also be considered as well. These, in summary again, the highlights of how the management for hepatitis can be in terms of treatment, with largely being promoted TDF, entecavir as well, and also TAF. When you look at comparing TAF and also TDF in the management of hepatitis B, you find that the outcomes are similar, but there is a rapid normalization of the liver enzymes, the ALT, on TAF compared to TDF. And this is in both those who have hepatitis E antigen positive and those who have hepatitis E antigen negative as well. That is largely the main difference. Otherwise, the outcomes are similar. So the European guidelines do recommend when you have to use TAF or over TDF, those that are elderly, age above 60, those that have bone disease, and also when you have renal disease as well. If someone has been exposed to nucleotide analogs, entecavir may not be the drug of choice, and TAF would be the drug of choice even in those who have these conditions. And this, again, is comparing the TAF versus TDF for hepatitis B, and this is similar again to what we see in HIV. Those who have enrolled under HIV in terms of the differences in renal function, where you can see that there is a slight margin favoring TAF for renal adverse events compared to TDF as well, and this was significant. The same thing with bone disease as well, where you have advantage towards TAF compared to TDF. Again, these are marginal benefits towards TAF over TDF. Another important point to consider also in hepatitis management is the fact that there's also cumulative resistance over years to 3TC, and that's why not encourage the use of 3TC with more resistance developing over time, similar to what we see in HIV, but almost zero resistance to TDF and also to TAF. And again, this looks at the type of mutations which you can see for the HBV variants and the resistance patterns. You can see that 3TC, there are a lot of reds indicating resistance to 3TC. But when you look at the TDF and TAF, only when you have the A181T and also the N236. That's where you have intermediate, otherwise there's sensitivity. And for this reason, then TDF and TAF are the preferred options for treatment. So really, when you come to the choice over TAF or TDF, it has to be looking at those individuals whom you think they have bone disease, those individuals who you think they may have renal disease as well, then you'll be able to go and give a TAF over TDF, despite the fact that there is also the increased normalization, rate of normalization of the liver enzymes for TAF compared to TDF. And so those who have aging, just like HIV, those that have hepatitis B, it's a chronic infection. So over time, with aging, higher rates of comorbidities are also encountered, including the CKD, osteoporosis, and in those populations, TAF would be a preferred option. Thank you so much.